We will move on to the next presentation for the day. She is Dr. Maheshika Gunaratna, Senior Registrar in Rheumatology and Rehabilitation Hospital, Ragama. She'll be talking to us on management challenges in rheumatology amidst constraints. Over to you, Maheshika.
Good afternoon, everyone. Thank you, sir, for the kind words of introduction. First of all, I would like to thank the Ceylon College of Physicians giving me this opportunity to present at the Young Physicians Forum in the month of September. So my topic for today's talk is management challenges in rheumatology and with constraints. I hope this is a common problem that we face in the day-to-day clinical practice. So that's why I chose this topic for the today's presentation. So in the introduction, these are the areas that I'm going to cover in my talk today. This is the introduction, followed by a typical case history, diagnostic challenges, management challenges, and how to overcome the problems. I would like to begin with this quote from one of the research articles. A century ago, syphilis was regarded as the great masquerade. Its modern equivalent is lupus. It may present to a wide range of specialists, and its outcome, while much improved, remain uncertain in a significant number of patients. So therefore, considering the wide variety of clinical manifestations, the outcome and particularly the unpredictable outcome, SLE is one of the difficult diseases out of all the rheumatological diseases. So I will discuss the management constraint mainly in relation to systemic lupus erythematosus. So in the introduction, the prevalence of systemic autoimmune diseases is about 3 to 5% in the general population. The clinical symptoms and signs are largely non-specific. So we need to prove the background autoimmunity with the serological testing in order to make a proper diagnosis. So ANA, which is the fundamental test in most of the connective tissue disorder, ANA disorder. So ANA positivity is about 10 to 20% in the population, although these figures may vary with the geographical changes. So the proper antibody testing with titer and pattern is the first step for the diagnosis of these rheumatological diseases. So these, as I said earlier, these diseases have a wide variety of clinical heterogeneity. So in most of the diseases, initial clinical manifestation can be very subtle. So the clinical features and the severity also vary widely among patients. And therefore, further testing is needed to decide on management options and to predict the long-term prognosis. So let me begin with the case history. This is a typical patient that we see in our day-to-day practice. So we have this 24-year-old previously healthy girl presenting with 1 month history of low-grade fever, loss of appetite, loss of weight, and joint pains affecting small joints of the hand. She gives a history of significant hair loss and a facial rash. She has noticed painful discoloration of 2 toes in the left leg for past 1 day. On examination, she was pale. She has erythematous rash in the cheeks, and she has multiple oral ulcers, cervical lymph nodes, and synovitis of bilateral metacarpophalangeal joints and proximal interphalangeal joints. And there is purple discoloration of 4th and 5th toes in the left leg with palpable pulses. So from the above history and examination, the first differential diagnosis that comes to our mind is systemic lupus erythematosus. But we are not sure. We cannot say 100% that this is a patient with systemic lupus erythematosus unless we prove the autoimmunity behind this in the background of this patient. So next, after the basic investigations, next step is to carry out specific investigations in order to confirm the diagnosis and to look at the extent of organ involvement to decide on further management and so how are you going to proceed to make a diagnosis? So these are some of the common serological tests that are done in autoimmune connective tissue disorders. ANA with teeter and pattern, double-stranded DNA, ENA panel, which include multiple other antibodies, antiphospholipid antibodies, lupus anticoagulant, myositis panel, and anchor antibody levels. So let me draw your attention to the prices of some of these serological tests. So these are the prices. I hope you can go through the list. So when we compare the prices of some of other investigations, these serological tests are extremely expensive. So these are paid either as out-of-pocket expenditure from our patients or as tax money from all of us. So what could be the management or the diagnostic plan in an ideal setup? When a patient comes, we take the proper history and do the proper examination. And after basic investigations, then we have to do some diagnostic investigations. So those could be ANA with teeter and pattern, dsDNA teeter in an ideal setup, complement levels C3 and C4, antiphospholipid antibodies and lupus anticoagulant. Now this comes because if you're suspecting SLE or when SLE is proven, it is in the guideline it is mentioned that screening for antiphospholipid antibodies is a must in these reproductive age females. And also, since this patient has an element of ischemia affecting digits, antiphospholipid antibodies are important as well. And then the anchor levels, since this ischemia would be secondary to vasculitis. So these investigations confirm the background autoimmunity as well as give the full picture of the patient, which will be very useful in the management. So in our setting, most patients cannot afford these tests. So the diagnosis and therefore the management decisions are made clinically based on the available investigations. So what happens when we make diagnostic decisions based on the available investigations? So patient assessment based on the experience of the clinicians or the treating physician carries an unwanted risk of variability. And this variability may have an impact on the quality of life, quality of care of the patients. So I would like to draw your attention to this study. This is a recent study which was done in 2023 April. But these data comes from Latin American countries, but even though it's from a different geographical area, I think this can be compatible to our context as well. So this study shows the impact of low socioeconomic status on SLE related outcomes. So you can see in this graph, in this table, the outcomes like mortality, damage, the chronic damage, the disease activity, major organ involvement like the renal involvement and the damage, and are increased in patients, particularly who are living in these low socioeconomic countries. And therefore, the work disability is also increased. And the mental functioning, which is important for their quality of life, that is decreased in these patients. So I think this is one of the important studies, and we can relate most of these things to our setting, even though the data from our setting is very scarce. So most of the patients suffering with these rheumatological conditions are young males and females who can contribute immensely to the country's productivity and economy. And SLE is a leading cause of death among females in the reproductive age. So the losses carry a significant burden to the country as well as to the family. And for the family, this loss is irreplaceable. So we will now, with that background, we will now move on to the management challenges faced in our day-to-day clinical practice. When it comes to the management, I would like to describe mainly these three areas. First is the availability of drugs, then the high cost of these medications, and the scarcity of knowledge on epidemiology and clinical features and the treatment response, particularly in the Sri Lankan context. So when it comes to the drugs, there are a variety of new molecules are being tested for rheumatological diseases each day. So as we all know, rheumatology is a fast growing field in terms of therapeutic. So there are a lot of new molecules that are coming into the market day by day. These are some of the examples. For systemic lupus erythematosus, we use belimumab, anifrolumab, and voclosporin. All these are not available currently in our country. And for inflammatory arthritis, targeted synthetic DMARDs like tofacitinib are used. It is currently available, even though the stocks, sometimes it's available in the government sector, but sometimes it's available only in the private sector. So it's again another good drug. Availability is not predictable most of the time. So what are the benefits of these newer therapies? They help sustain improvements in the disease activity, and there are higher rates of long-term remission, which are proven in studies, and it also reduces the glucocorticoid exposure. So glucocorticoid exposure is linked to serious infections, which are the principal cause of mortality in both high-income countries and low-income. The risk is more in low-income countries for obvious reasons. And minimization of the progression of organ damage, which adds up to the chronic damage. So these are some of the benefits that we see with these newer therapies. And the next problem is the high prices of these biologics and other disease-modifying drugs. It's needless to say that the prices are high. There is a significant problem. This is a significant problem not only in our country but in developed countries. Particularly when we are thinking of continuing these medications for long term, cost has a significant role to play. Efficacy is proven in most of the clinical trials, so there's no doubt about the efficacy. But when it comes to the safety, we only have short-term clinical data about the safety of these drugs. So what about the long-term safety? We actually do not have much experience because these are newer drugs in the market. So in reality, expensive medicines must still be proven to have long-term clinical benefits in individuals with these rheumatological conditions. So how can we overcome above challenges? For that, this SLE, I would like to say that SLE management is a prolonged spectrum. And this spectrum includes multitudes of actions operating at different levels and may vary from early diagnosis with access to care and the therapies and also giving supportive care for the patients. So in this spectrum, I told you there are different levels. So these levels start from patient, of course, and also the treating physicians. So most of these diseases involve multiple organ systems. So therefore, multidisciplinary team management is needed most of the time. And also not to forget the patient family, which is very important in the management, and they have an important role to play in the management. And other stakeholders like regional, national, and international organizations have also multiple roles to play in this management spectrum. So what are the potential solutions that are available to handle these situations? Even though the number of patients can be less, of these autoimmune connective tissue disorders, when we take the overall disease burden, it's very significant when we consider these diseases. Therefore, I think these diseases needs more attention than what is given now. So first and foremost, identifying these rheumatological diseases as a primary health concern is one of the main things in the management. So thereby we can aid fruitful distribution of funds to give a proper care for these patients suffering with connective tissue disorders. So what are the other potential solutions? Mainly, if we talk about our role as clinicians, these are the things that we can do to improve to solve this problem. Early diagnosis, for that you need to have thorough clinical experience and knowledge to make a proper diagnosis, to catch the clinical symptoms and signs early, and not to miss other differential diagnoses. Health education of the patient and also the family members, and also the health education of the other members in the health multidisciplinary team is also important. Achieving remission or low disease activity early, that is again another very important step, and medical education programs, as I mentioned earlier, and the monitoring of adverse events. When we start treatment, there can be these drugs are very toxic. Where we give immunosuppressant to most of the patients, and even the painkillers, they can have a lot of adverse events. So it's very important that we have a continuous surveillance of monitoring these adverse events, and also ultimately preventing chronic damage by uh, achieving the control of the disease. So all these are few steps that are important at our level. So we can definitely intervene, and much can be done to improve above outcomes as I discussed. Another area that can be a potential solution is to stimulate research that study the epidemiology, clinical features, and treatment response. And it needs to evaluate the cost effectiveness of available therapeutic options. Even though these therapeutic options are available, we have to analyze the cost effectiveness before embracing these therapies. So these are important to make an accurate estimation of the disease burden in patients with these rheumatological diseases. This is another very important area. As we all know, the prices of original products, particularly the biologics, are skyrocketing. The alternative is to use biosimilars. The biosimilars and the generics. Biosimilar is a biological medical product that is almost similar to it's almost an identical copy of the original product, but that is manufactured by a different company. So it should be similar in terms of quality, safety, and efficacy, but considered to be having a lower price. Establishment of international funds which promote the acquisition of quality drugs at a lower or reasonable prices is another possible intervention that can be done. But the stakeholders are different here. And to participate in collective multinational transaction is also another important aspect in the management. So this slide summarizes the intervention that I discussed so far, how we can overcome the above challenges, above diagnostic and management challenges, to provide best possible care to patients with these systemic rheumatological conditions. So in summary, autoimmune rheumatic diseases can lead to a significant disease burden, especially in low-income settings. The diagnosis of autoimmune rheumatological diseases is a unique challenge to the treating physician. So management comprises of a spectrum of interventions, and economic crisis affects adversely on both diagnosis and management, and potential solutions to overcome above challenges operate at different hierarchical levels. So finally, I would like to thank my trainer, Govinda Munidasa, consultant rheumatologist and rehabilitation physician, who is also the president of CSDP, for giving me this wonderful opportunity to present today's session, and Dr. Gayani Premavasa, who is my pre-MD trainer, and all my colleagues and family who supported me throughout the campaign. Thank you.
Thank you, Maheshika. It's again open for questions. Yes, Supur. Very appropriate this broad context. Do you see increasing the mobility and mortality these patients with autoimmune disorders after the branch of rheumatology?
Well, I would say yes, because one thing is when they initially come for us, sometimes if we do not have a proper diagnostic tests at hand, so we are a bit reluctant to start on therapy. So if we can have, because one of the main reasons is even a proper ANA report is not available in the government hospital. So we have to rely on patients until they get it done from other hospital, right, from private sector. So when these are delayed, so only the management is solely depend on our clinical basic investigation and on the clinical picture. So therefore, I think there is a delay, and that affects the patient. And in another when it comes to the management of these patients, usually, like if you talk about some of the patients who are on biologics, they do really well with. I'm just talking about patients who are on biologics. Some patients do really well with these drugs, but these days some of the biologics are not available, and because of that, we see some of the uncommon manifestations of the diseases. Like, for example, if I take axial spondyloarthritis coming up with large vessel vasculitis, something like that. So when we are not able to provide them with proper treatment, timely proper treatment, like if we sometimes we can find the drug, but there is a significant therapeutic gap, and that I think allows the disease to progress and make more damage. So I think there is a significant impact on patients. There are studies done, and it is found that the flare symptoms have been increased, but I don't know about the long-term damage. So I think that we need to study a little more on that.
Yeah, continuation. When you assess the outcomes, what are the therapies you normally use in your patients? Is it parameters like ESR or quality of life of the patient?
So assessing the outcome in sense like in the short term, when we start them on treatment, we do the clinical assessment of the clinical symptoms together with some investigation. So most of the investigations actually basic, like the full blood count, ESR, the urine analysis, the UPCR, those things. We do not have access to I think dsDNA antibodies, which is a very good investigation, which becomes positive early in the disease, is not available. I mean, to my knowledge, I think we are not using it currently. And also the complement levels, again, the same. Other outcomes like we can assess the chronic damage by using various questionnaires. And also we can assess the disease activity by using, there are standard questionnaires. So these can be used to assess the outcomes. And also the mortality rates.
Thank you, Manchika. We have a token of appreciation